Mkoaje? You look bored. Honestly, you look bored. Okay, I'm Sharon Moeni. I'm a fourth-year student. Yeah, I'm taking biomedical science as a course. And before we start, or maybe to break your boredom, I want to teach you a slogan. Nikisema hashtag, mnasema antimicrobial resistance. And nikisema hashtag, mnasema handle with care. Sawa? And mkuwe energetic. Hashtag. Hashtag. Yeah, you can do better. You can better. You can do better. Hashtag. Hashtag. Yeah, thank you.
Yeah, to start, already you know why we are here, is it? And again, we are many causes here. So what we represent is just some clues and ideas of what brought us here. First of all, what is this antimicrobial resistance? Next, as our course of biomedical science, what is our role? Because you'll find that the pharmacists have their role in this field, the doctors too, nurses, and so on. What I want to focus on is just our role as biomedical sciences. At first, what is this antimicrobial resistance? It is the ability of microorganisms to persist or grow in the presence of drugs designed to inhibit or kill them. Yeah. Another thing, when these microorganisms become resistant to these drugs, there are many signs you can see, there are many symptoms. First of all, our main aim in hospitals, other things, is to reduce this treatment cost, but you find that when these microorganisms resist the drugs, there are many costs that patients occur. And you know that even here where I'm standing, my fingers are not the same. So as fellow health scientists, doctors, pharmacists, biomedical students, what we should do is to come up with different ideas, clues, and so on. So under this, infections become harder to control. Do you agree? Yeah. We move on to how does this occur? You find that the microorganisms, they are organisms due to errors during replication and environmental factors. Again, we have the horizontal gene transfer, that's the HGT. Yeah. The conjugation, transduction, and transformation. Again, misuse or overuse of antibiotics, and I believe that everyone has done this. We don't complete our doses. Again, we just do the over-counter drugs. As long as you see, I'm a second year, I'm a first year, I'm a fourth year. If I have a headache, I just assume, let me go for a paracetamol. Let me go for amoxicillin without knowing the cause of that headache. No, don't shy off. Even if it is which disease, just go. And we know the main cause, we help you. Instead, we just go for the cheap one, the shortest cut, not knowing that the future will have many, many more causes which will injure our life, guys. And again, this thing, how can we combat it? How can we, what first thing, develop of new therapies? Yeah, this is where you find now scientists have really made their time to come up with the new things, guys. This is where we should look forward to. As your fellow, and again we share the same vicinity of Kisii University, we should come up with the ideas that one day outside there, we reduce. You know, sometimes we say that, yes, we work effectively, but sometimes efficiency the best. Where we find that efficiency, we use less time, cost, and what? Resources. But effective, we share the goal. The person who is working effectively, the person who is working efficiently, they share the same goal. The goal is to reach there. But you find that the guy who is working effectively, whichever the resources, if he spends a lot, the main aim is to reach the goal. But efficiently, yeah, we reduce cost, time, and resources. Because you find that some patients can't wait for that long, can't wait for all those. So we need to work efficiently. And how can we work efficiently, guys? Share ideas, symposiums like this, guys, we come and no one to. And again, another thing, how to combat this AMR, improve diagnostic and surveillance. Another thing, infection prevention and control, antimicrobial stewardship. Yeah, from that point, I just conclude and thank you for giving me your listening ear. Thank you.
Sijaongea though. I feel like I should talk juu at least nimesimama mbele. And then I also feel like we are really focusing on understanding what AMR is, that is how it occurs, the causes, all those, which is good, but I feel like we are avoiding the how do we prevent this AMR? How do we fight? Not that it's a public health concern. How? What is our role as scientists? You see what hapa we are scientists. And hapo sasa ndo the aspect of educate, advocate, and act now is coming in, right? Yeah, so as biomedical scientist, I think my colleague has mentioned, but I feel like I should emphasize more on these new therapies zenye tumesema, like we tunakuanga na that we research or we come up with other ways of fighting this antimicrobial resistance. And one of the key things that, or one of the key alternatives that is emerging right now is a phage therapy. I know kila mtu amesikia about phages, you know? Yeah, and we all know that phages ni hizo viruses which fight or rather kill bacteria, right? Yeah, and so these phages, it's actually, vile nimesema, it's an emerging therapy, yeah, an alternative to combat this antimicrobial resistance. And what scientists are doing, they are using these viruses. Okay, let's say someone is infected with a bacterial infection and this person is not responding to all those antibiotics. So they come up with a way of introducing live viruses, yeah, to that patient. And easy viruses, they kill the bacteria, or rather inhibit the growth of these bacteria. Yeah, and as an organization, I feel like I should mention this, we came up with a certain club. Okay, saindo inaanza, yeah, inaitwa Phage Hunters and Training Research Program. Yeah, and hapa ndo we learn more about phages, about the mechanisms, about how they kill these bacteria. So, yeah, so you can still join us for more, you know, tukilearn how to fight AMR, then tutakuwa tumedefeat, right? Yeah, so that's all. And as I finish, I want to leave you with a certain, okay, sijui kama nitaita quote, but yeah, it's a quote. Inasema antimicrobial, resistance is not a distant problem. It is influenced or fueled by our habits. So, yeah, hashtag. Oh, kulikuwa na handle with care. Oh, hashtag. Yeah, thank you.
Thank you. Give them a good clap. Yeah, so as you can see, others have drugs. We uko na nini? Before we continue, the next presenter is Origi Rigan from Clinical Medicine. As he comes, maybe we can do one thing. I have a question. I will be asking it, then mtu atapata. Niko na zawadi yake. Sawa sawa. Yes. First of all, Sharif, tell us what you've learned so far. Yes. Pass it to Sharif.
Yes. Good afternoon. No, first of all, big to the facilitators. Oh, so I love to repeat myself. The keyword I'm going to repeat is facilitators. So, under the stewardship of our congressman, our doctor is in the room, Dr. Titus, our Mrs. Yeah, for making this happen. You know, I'm not used to such events, but this is the first time. Yeah. So, this is the blueprint of our school. Yeah. So far what I've learned, you know, becoming a medic, at the end of the day, you will realize everything is a poison. Even me alone, I'm a poison. Yeah. So the misuse and the overuse, yeah, that's what I've learned. The misuse, the overuse of the antibiotics. It will interfere with this common infection. You have a malaria. By the way, first year, at the end of 5-year course, I pray that outside there, I don't be considered as a quack. Yeah. So finally, just a minute. Finally. So we still need more events like this. Yeah, I think these are events that all the school, you know, what I like about this school is the diversity. Yeah. So these are things which the whole school will resonate with, even if you are in nutrition, pharmacy, whatever. Yeah, so we always learn a lot. So thank you very much. Yeah.
Yes, thank you, Sharif. Be very careful when you are here. Teddy, I hope you are taking notes. I was to ask a question very fast. Penicillin was the first antibiotic to be discovered, right? Yeah, so I'll be taking one person from this side and this side. So I just want somebody to spell it. Very, very fast, yeah? Penicillin was the first antibiotic to be discovered. Just spell it. One person from this side, one person from this side. Yes.
Penicillin, we have Penicillin. Penicillin.
Thank you. Amepata? Okay. Haya, hii upande mwingine, Obama, nataka kuspell.
Okay, penicillin, double L.
Thank you. Nyi wote mmepata answer, but hamjapata answer ya swali yangu. Mimi nimesema spell it. It ni IT. Sawa. So next time let's be very, very keen and get these things right. They are simple stuff like using the drug rightly when it is prescribed, and we don't do it. So next time nikiuliza swali, angalia ndani na nje. Sawa. Yes, Origi.
Yes, thank you. Good afternoon. So up to now, I am certain that mshajua what's AMR, mshajua what's causing AMR. Yeah, so I won't repeat that. I'll move to our roles in preventing AMR and the challenges that we face as health practitioner. So one of the challenges that you find, we challenge is diagnostic delays. Yeah, so a lack of adequate diagnostic delays or even limited laboratory capacity can make a clinician or a medical officer to prescribe a broad spectrum antibiotic. Yeah, so that is one of the challenges that is causing such. So we have diagnostic delays, and we also have patient pressure. The patient is coming to that, when you pay you ndio nataka. You see? Yeah, so patient pressure is also a challenge that we face as clinicians. Poor adherence by patients. You prescribe a drug to be taken after every 8 hours, and then the patient is taking it after 12 hours, and then after 2 days puts the drug away. So that is also a challenge that clinicians face. Limited antimicrobial options, because there are few effective drugs, because majority have a rising resistance. Yeah, and again, high workload. There's a high workload. You find that, so kuna line kwa usi, mtu anasema tu sinile tu ninunue pale dawa, itakuwa imeisha. Yeah, so what is our role? Yeah, the role that we can do to make sure that we prevent and control antimicrobial resistance. One is to ensure that we have accurate diagnosis. So as clinicians, we must differentiate bacterial infection from viral or non-infectious causes to avoid unnecessary antimicrobial prescriptions. And again, we have to do rational prescribing. You don't prescribe. You have to use antimicrobials only when indicated. Yeah. And again, if a patient comes to you and you are suspecting, if you are suspecting a bacterial infection, you are going to start with broad spectrum antibiotic. So immediately after getting the lab results, so you have to de-escalate the therapy from the broad spectrum to the narrow spectrum. Yeah. So there is a role that we play to ensure that the resistance does not occur. And by educating the patients, we are the future health practitioners. That's why I'm telling you this, because tomorrow you are going to be the person doing that. So by educating, patient education is very important. Advising patients on adherence and telling them the importance of avoiding self-medication. Yeah. So you have to tell the patient, because most of us have normalized it. So medical students will just say, let me just read the notes after all. Yeah. So, but you will read the notes and maybe it requires lab result, your case, to ascertain that it is what you are thinking it is. Yeah, so you have to avoid self-medication. Even if you are a medic, don't just read the notes and go and buy drugs. Okay? That is the joke. We always say it as a joke. We are not serious. Yeah. So again, how we can help to stop this again is you can order for culture and sensitivity. Yeah. When a patient comes to you, don't just give a broad spectrum and send the patient home. No. Order for culture and sensitivity so that you can get the specific microbe that is affecting the patient, so that you can prescribe the narrow spectrum, the exact drug that is supposed to be used for that case. Yeah. And also by reporting, you know, if you realize that a certain drug is not working on a patient, you have to report, yeah, for surveillance to occur, yeah. So I don't have much to say. Just to conclude that as health sciences students, we play a very critical role in preventing in preventing AMR. And one of them is by ensuring that we tell our colleagues that may not have the understanding we have on it, that self-medication is wrong. Yes, that is actually the biggest thing. Yeah, and again, I don't know if they've mentioned, the previous I've mentioned, but there's this called growth promoters in animals. Yeah, so antimicrobials like tetracycline are frequently used in chicken feeds, and you end up eating them. So growth promoters also is a way that it causes, yeah. So let us just make sure that we tell our colleagues to avoid self-medication and always seek qualified medical practitioner. Qualified is very necessary. Thank you.
Thank you, Origi. We'll move to the last presentation from our departments. That is from the nursing team. I don't know if they're there. That is Patience Mudeu and Fidel Castro. Are they present with us? Yeah. As they come, allow me acknowledge the presence of our KSUSA president. Sydney, you can wave. To them, you will get a chance to speak before the event. Wave. Yes, thank you. As they are coming, allow me give you a quick one. Simnataka a quick one? A very quick one. Now, how do we call, you know the plural and singular form, right? So what is the plural of a prince? What is the plural? Yes, Obama, a prince, the plural of a prince. Now there are many princes together. How do we call them?
There are many princes together. A group of princes.
No, it's not princesses. Okay, we'll find out. Thank you.
Good afternoon. Thank you for this opportunity. My name is Fidel Castro, year 1, doing nursing. Now, according to this AMR, I think all of us has understood the main cause, everything and how it occurs. Now, it is my role to now highlight the role of the department, and mostly in this AMR, I think the nursing department, it plays a major role more than the other departments. And if I'm lying, yeah, I'm very confident about it. And if I'm lying, you can just move out. Yeah. Now, the reason why I'm saying this, first of all, you find that the patient's customer care is about being a nurse. Yani, we have that communication. It first starts with us. So nurses fight these crises mostly, and I think majorly it is us fighting it more than the other people. Now first, we have patient and family education. The nurses, they act as communicators. You find that when patients they're having problems in terms of these diseases, it is the nurses that they carry out the research on the problem that they have, and then the other thing, they give them advices according to what they should take, yeah, like that. And then the second thing, we have the surveillance and data collection. We find that when a patient visits the hospital, it is first the nurses that will carry out the research on the feces, urine, and will advise them accordingly. Then the third, we have, just a minute, I think the infection prevention control. First of it, these bacteria, they first, I think mostly are communicable. They cause communicable diseases. These are just like tuberculosis. You have the Mycobacterium tuberculosis, that's the bacteria. So to me, I think as these bacteria, they can be transferred from one patient to another. And also within the genes, we have something known as the horizontal gene transfer. These genes, the bacteria can transfer these genes from one bacteria to another. So we find that nurses, they act first. We find that they doing hygiene. They're the first people to wash their hands, showing the patient on how to carry out the ways to combat these crises. The other thing, ways on what type of food to take, yeah, those. So as I conclude, I just want to say that in fighting this crisis, if we left nurses behind, I think combating this thing, it must be hampered with. So just involve us. Thank you.
Good afternoon. I am Patience Mutheu, a second-year nursing student. I'd like to re-emphasize on some of the things that he said. One, as nurses, we play a key role in patient education and community education. So now when it comes to antimicrobial resistance, we are the people to go to the communities, teach communities on, number one, proper use of medication, that is completing doses that have been administered. We are also the people to go to the communities, teach them that they are not supposed to self-administer medicine, also teach them that they are not supposed to recycle medicine. If your firstborn had this disease and they have similar symptoms, you're not supposed to give that other child the same medicine the other one had. Those are the things now we are supposed to be teaching the community. Again, as the patient advocates, we are supposed to advocate for the patients to the doctors and the other members of the healthcare team. That number one, you re-emphasize and do better testing, wider range of testing, so that you narrow down on the spectrum of antibiotics being used. This one will ensure that, number one, you will lower the risk of developing the resistance. Is that okay? And again, there are some of the challenges that we as nurses will face in the field when we are combating antimicrobial resistance. Number one, that is extreme workload. When we have extreme workload, we will not be able to concentrate and give our whole when taking care of patients. We find that you have about 10 patients, you're working alone, you're feeling overwhelmed. So the chances of you remembering to take the proper precautions will be low. You might be transmitting the infections from one patient to the other one. Again, we have knowledge deficits. Some of the nurses who are already practicing, and also the student nurses, as they go to the rotations and the nurses are practicing, we have a deficit of knowledge on how antimicrobial resistance is developing and how to take care of this. So we should encourage the education of even of the existing nurses, the student nurses, and the ones who are already in the field. Thank you.
Yes, thank you. Thank you. That is a very good presentation. And that being said, I think we are only left with like 2 presentations. Then that is from our guests. Then we'll quickly move to the panel. And before that, we have a presentation from a very dedicated musician, Obama Paul is a musician. He is yet to know, tutamsupport aende mbali asirudi. But in the meantime, atu entertain kidogo, then we'll receive a brief presentation from our doctor, Dr. Gazikira, then a brief one from Dr. Helen, then we'll move to the panels very, very fast. Musiboeke, I know it's lunchtime. We have something for you. Sawa sawa. Yes.
Yeah, I thank you, Mr. Congress, for the opportunity. And before I present, I have a presentation and I'll present it in spoken word form. But I want to tell you that this information is not only for you. You are medics. You are given this information so that you go spread it outside. I know I'm going to use English and maybe some are going to pass, you are not going to get them. And I advise you may use your phone and record a video and go through it afterwards. So the DJ, instrumental is Time by Hans Zimmer. Yeah, so we are waiting for him. As we are waiting, I thank you for coming. It's a sacrifice. My name is Obama, but many people call me with many different names. Some call me Paul, others Paulo, and few Paulus. They say I took a name of a president of former of USA, but no, he took mine. He took mine is that he was born earlier than me. And that is, how is that my failure? I am here to try. Because I've never had one die of trying, and it's good to die trying than dying without trying. Antimicrobial resistance, the silent tsunami. Listen, can you hear it? It's not the bang of a bomb, not the crash of a quake. It's a whisper, a microscopic mutiny. It is the river of a bloodstream in the warm, dark cities of a land. A treaty is being broken. A truce generations old is shattered. They were our miracle, our magic bullets, penicillin, the chance spore that saved the world. They tamed pledges, they made surgeon into sculptors. They turned a scratched knee from a death sentence into a bedtime story. We call them antibiotics against life, but we meant against their life to serve us. And we were so victorious, we got careless. We handed out these silver bullets like loose change, taken them for cold, the flu, the just in case. We fed them to our livestock by the ton, creating a billion tiny training grounds. And in the petri dish worlds, a lesson was learned, a Darwinian drumbeat, adapt or die. And they adapted. The pneumonia that once knelt now stands. The UTI that was a minor inconvenience now a siege. The staph infection that stayed on the skin now walks the halls of our hospital clad in armor. This is the silent tsunami, a flood rising not from the ocean but from within. And when the wave finally breaks, a scrapped knee will be a death sentence once more. A C-section becomes a game of racial roulette, cancer chemotherapy, too dangerous to try. We are marching, armed with sticks, towards a dragon we once laid with a sword. So what do? Do we whisper our eulogies for modern medicine? Or do we remember our power? This is not a war we can win with bigger bombs. It is a war we can win with wiser strategy. It is the doctor who prescribes not out of fear but out of knowledge. It is the nurse who guards the gates of Ivy Line like a fortress gate. It is the farmer who chooses stewardship over supply. It is the next scientist in the lab chasing the next dawn. It is you. Yes, you. It is your hand washed clean, not with paranoia, but with purpose. It is your question, doctor, do I really need this antibiotic? It is your commitment to finish the entire course even when you feel fine. It is your choice to demand and support the change we need. We taught them how to resist. We must teach ourselves how to persist. So let our voice become the new resistance. Let our actions be the new prescription. Not just for us, but for the child yet to be born. For the future we have not yet written. Let our legacy not be that of a generation that destroyed miracles, but the generation that was wise enough to save them. The silent tsunami is coming, and we are the world. Thank you.
Yes, thank you Obama. Mmeonaje hiyo presentation? Ni fire si fire. Ni fire si fire. Ni fire. Sasa tumesema tunampromote aende mbali ama abaki. Aende mbali sina. Abaki. Amalize kwanza. Mokoyo, tell us what you've learned. Thank you for speaking. Yes. Let me bring the mic.
Good afternoon. First, some say he took the president's name, but the president took his powerful one. On a serious note, I've taken a lot from the presentations made today about the antimicrobial resistance. And I think it's now my part to act. Thank you.
Thank you, Frank. Let me pick one lady. Na mnaangalia mbele sana, jamini. Aha. Yes. Tell us something you've learned from the Holy Vet. Tangu ianze. Kitu moja tu. Kama ule mzaka anaweza kukusaidia. Yes, msaidie.
Hi everyone. My name is Jackie Omondi, and I've learned that antimicrobial resistance, it's a silent tsunami that is coming. Yeah.
Yes, thank you. From this end, Ustad. Yes, Ustad.
So my name's Wilkins Melezanawi. Many know me as Ustad. First of all, let me recognize Oyugi. Oyugi tumefanya naye kazi sana. And whatever we are about today, it is about antimicrobial resistance. And that is all.
Thank you, Ustad. Okay, let me find a lady from this end. Let me see. Angalia tu mbele straight, sitakuchagua. Angalia tu mbele straight. Mbele straight.
Okay. Hello everyone. My name is Nicole, 2.1 Pharmacy, and I have learned what AMR is, its prevention, and more importantly, how to fight it from the biomedical lady. Thank you.
Yes, thank you. Let us give is it 2 factorials? 2 ni mingi ama? Gani ni mingi? 3 ama 2? 1 factorial ni ngapi? 0 factorial ni moja, si ndio? 0 factorial ni ngapi? 0 factorial ni moja. Give them 3 factorials. Obama, can you lead the clap? Hiyo factorial. Okay, sawa. Haya, before us is a doctor. Sawa. we have one of our own doctors. Yeah? One of our own. Kisii University product. Kisii University alma mater. This is not just a doctor, but a real deal outside there. So when you see daktari pale nje, give him the respect he deserves. Let me introduce to you Dr. Kasikira. Hata sijamaliza. Before niende kwa daktari, he is a football coach. He is the coach of MBCHB team. He is an ardent and ambitious supporter of Arsenal Football Club. And somebody was saying that the act of washing your hands from a tap without using a cup is called Arsenal. Because you don't need a cup, right? You just need to wash your hands. So, but this year, we are hopeful maybe you can surprise us. You become number 3 or number 2. Allow me introduce to you Dr. Kasikira Titus so that he can talk to us. Thank you, Doctor.
Thank you, Yugi. Good afternoon. My name is Titus Mutua Gashikira, and yes, I am a medical doctor. We'll have many discussions today, but to start us off, before Dr. Helen presents, I will just do an overview of what the other presenters have presented. But before I start, I will start probably by correcting something that Rollins said earlier on. He said categorically that Sir Alexander Fleming was the first person to discover an antibiotic, right? But is that true? Is it true? Is it true? Who discovered Lake Victoria? Who discovered Lake Victoria? It captured correctly from the history that 3,000 years ago, Nubians from South Sudan were using antibiotics, specifically tetracyclines. So how comes now that Alexander Fleming, until 1929, is the one who is recognized for discovering penicillin? And we all agree with that. Can we agree with that? Can we? Okay, just to pick from where Alexander Fleming left in the year 1929, what happens after he discovered the penicillin in 1929? Later on, there came the Second World War. Then you remember from the First World War in the year 1914-18, we had very many troops dying from infections. They were injured, dying from infections. But now comes the Second World War, and we have a penicillin which saved very many troops from death from simple infections. And through his works, Alexander Fleming won a Nobel in 1945, he won a Nobel. How long do you think it took for the first case of resistance to be noted? How long do you think it took? 2 years later, after 1945, 1947, we had very many cases of penicillin-resistant Pseudomonas. I know we know of methicillin-resistant Pseudomonas, but we didn't have methicillin at the time. We had penicillin-resistant Pseudomonas. And Alexander Fleming, in his speech in 1945, he was very categorical that he couldn't foresee an event where there would arise a resistance to antibiotics. And he said that any person who dispenses the antibiotics just anyhowly, they will be morally and also professionally accountable for any death of any person that will occur later on, because the infection that would probably result probably in the years to come will not be able to be treated by the antibiotics that used to work at that time. And it sounds that probably many of us here will be held accountable for that, both morally and also professionally. But now I would ask the presenter just to present something. We might talk about issues. We talk about things that the other presenters, they mentioned about genetics, they mentioned about mutations. But I want us to come back home, like we come back to the real patient. You see how this really is affecting us in the ones. So this, just the next one, we'll come back to this one. So from this you can see it's a patient whom Pseudomonas aeruginosa was isolated. And from your microbiology, Pseudomonas aeruginosa is a gram-negative, I think, motile rod, right? And we know the treatment for Pseudomonas aeruginosa. Since time immemorial, we have been treating Pseudomonas aeruginosa with the piperacillin tazobactam, right? Now we isolate this organism. We decide to do culture and sensitivity. Of course, for any patient with suspected Pseudomonas aeruginosa, we do culture and sensitivity. What can you notice? What can you notice from these findings? I have less than 5 minutes. What can you notice? Is it a sand scene? Is it a sand scene? Or you are so excited to see this from your patient? Dr. Acheng will be very worried if she comes across this one. So this is a patient that we had. So you can see all the common antibiotics. The organism was resistant to all the common antibiotics. Even down here, you can see your piperacillin tazobactam, which is the first line agent. It's resistant to it. Now you ask yourself, what's the next move? You have a patient in the ward. The organism is resistant to all those common antibiotics. It will come a time when we'll be avoiding to do the procedures in the ward, fearing infections. I mean, like a patient cannot have a knee replacement surgery, patient cannot have a cataract surgery, because we are more worried about the infection rather than, I mean, like a person can survive without knee replacement therapy, knee replacement surgery, right? But what if they develop this infection after the surgery? That will be our greatest worry. And I think it's Otuoma who mentioned that our savior will be probably discovering new drugs. Probably it's not, because when you look at the pipeline between the last century and this century, when do you think we are discovering more antibiotics? Between the last century and this century, when do you think we are discovering more drugs? In the 20th century, right? So when you look at it, probably the new therapies might not even be the solution, but advocating for AMR and looking for every other way to curb all this nonsense that is resulting probably from what we do out there or from what we fail to do. Because when you look probably from even our laws, it's very clear. It's very clear on whom can prescribe, on who can't prescribe. But everyone else is just prescribing medication just everywhere. And CAP 244, I think Dr. Cheng will agree with me, it's very clear on who can prescribe and who can't prescribe medications. But now, let's go to the other patient. I just want us to see it so practically. we might talk about it here, but it may not make sense if you don't see the cases of real patients. So this is a patient whom, after doing a high vaginal swab, E. coli was isolated. Then we decided to do now the sensitivity. So this is what we discovered. What can you see? What can you see, Regan?
I can see it is resistant to quite a number of drugs there, quite a number of antibiotics.
So, is that something that you would like to see from your patient? Probably not, because there is something which is called One Health approach. When a patient works in an hospital, it's the responsibility of the gatekeeper, is the patient's responsibility of the nurse, the clerk, the doctor, the lab tech, the nutritionists, mention them all. It's One Health approach. So I will beseech each and every one of you, can we try to become these now ambassadors? Can we now try to become the people that will go out there and make sure that we stop this AMR? Because it's going to be, as they said, it's not going to be a pandemic. It's a pandemic. You can see it's happening. From what Brighton presented, is saying that 1.26 million people are dying from indirectly or directly from this menace. And it was projected that the data that you highlighted was from 2019. It was projected that up to 2050, these numbers will increase by over 70%. Cancer won't be an issue. This one will. And the other presenter also talked about the phages and so, but they won't be a solution. We have to protect the antibiotics that we have. We have to protect the antimicrobials that we have. Oh, yes, today we'll be discussing more about antibiotics, but the whole discussion is about the antimicrobials. Because I remember, I think 3 months ago, we have a patient in the ward, a small child. We decided to do, the child comes with all the signs and symptoms that probably would point towards malaria. Yes, we do. We decided to do the point of care testing. We do. Then we discover this patient has malaria. Then we do the gold standard, which is the swab. I mean the slide, malaria slide. It's positive. Then we start the patient on artesunate, because this could be severe malaria. Of course, this is severe malaria. We start the patient on artesunate. Artesunate is the first line drug for use of in severe malaria. And Dr. Acheng would agree with me, for malaria, for a patient with malaria, if you start the first dose of artesunate, before you can even administer the next dose, you can clearly see improvement. You administer the first dose of artesunate at 0 hours. Before you administer the next dose, you can clearly see improvement. But it's a patient with malaria. We have administered the first dose of artesunate. The next time we review the patient, they are deteriorating. We administer the second dose. In a day, the patient is still deteriorating. And for sure, this patient has malaria. Then we decide to consult, because everyone believes that, oh no, anyone can treat malaria anyway. Then later on, through consultations, we discover this patient, probably they are having artesunate resistance. We decided to switch to artemether. No, we decided to switch to quinine first. And within the first dose of quinine, the patient improved approved. And then we noted through the study, because that's why I'm beseeching each and every one of you, let's now get into research. Because we later on discovered in the area around Mwembe and Gekomu, there are emerging cases of malaria. There is artesunate resistance there. So if that patient from that area comes with severe malaria, probably you would not love to start them on artesunate. Probably when you start artesunate and not working, you should probably consider starting them probably on either quinine or any other drug that probably could work where artesunate can't. So these are the discussions that we'll be having with the panel, and thank you so much for attending. We'll answer all the questions that we are having, and we'll also try to shed some light, and I believe that by the end of this discussion, each and every one of you will be an ambassador, and will go out there preaching the gospel, the good gospel against the antimicrobial resistance. Thank you.
Yes, thank you, Daktari. Thank you for being very brief. We want to have a panel just after Dr. Helen has presented, and the panel will delve more into it. Sawa sawa. Yeah. DJ weka ngoma moja at least tusikie daktari akikuja. Mnataka ngoma gani? Mnataka gani? Mnataka My Darling? Ah? Azizi. DJ eka. Inda no. Dufla hii donjo mafine hii kitu hiyo inaitwa donjo maber, si ndio? Eka hiyo. Haya, tusimame tu dance. DJ unaleta mchanganyiko. Weka yeye.
Ikibamba sana basi pulito. Select a chesa doba once from the top. Nisha speaker, mashito. Let it up. CBD, your penthouse. CBD, you need your stuff. Lakini kiabidi, unazoza. Makamiti, unakunangoja. Nabeba joni paki, ukipenda kipepo. Napenda tena, na utetemita. Usalimia mwana kibutu na napenda vile mashala, mekuja wamebeba. Napenda vile mama zepita, wamegiva. Ikibamba sana basi kulito. Select a chesa doba once from the top. Nisha speaker, mashito.
Nitawadansia mmoja kali before tumalize. Sawa sawa. Haya. Allow me introduce to you. Haya, sawa. Dance vizuri after panel. I promise you nitawasakatia. Sawa sawa. Nitawapea moja kali. So I want to introduce my profession, a pharmacist. Yes, a pharmacist. How many pharmacists are there? Ni bado si pharmacist. Sasa nyinyi ni makwak. Sawa sawa. Yeah, but thank you for being ambitious. I am also ambitious. Sawa sawa. So we have our doctor. She is called Dr. Helen Achieng. She is a doctor at KTRH. She's an expert in epidemiology. She is well conversant with the AMR, and she has a brief presentation before that. Then we'll have a panel where we'll discuss AMR in details. Then it will be the end of this event. Muhold tight, sawa sawa. Na tuchukue notes. Najua njaa inaweza kuwa imeingia, elements of njaa, but just unabend tu kidogo hivi inapita. Sawa sawa. Yes, let's be patient. Najua atachukua time mingi na vitu zitakuwa sawa Sawa sawa. I failed to inform you of the slogan. When I say AMR, you say act now, protect our present, secure our future. Sawa sawa. Sawa. Si refu. AMR, act now, protect our present, secure our future. Sawa sawa. Haya, sasa acha niseme vizuri. AMR, protect our present, secure our future. Haya, AMR, secure our future. Thank you. That is our theme. Welcome, Daktari.
Hello, everyone. Good afternoon. My name is Dr. Helen Achieng Okumu. I'm a pharmacist at KTRH, and I've specialized in pharmacoepidemiology and pharmacovigilance. Currently, I am the county pharmacovigilance focal person, but today I'd like to step in for my colleague who is on leave, who is the county AMS focal person. So I'm here to represent him. I hope I'll do a good job. So I've been listening keenly on what you've been saying, and I'll admit that I'm quite impressed with the knowledge background that you have. So for me today, I'd like just to emphasize on specific points that I've noted while listening, just to direct us more on the path of AMR awareness and how we can be involved, putting point on that we are the future generation for this country and for this world, and we are the future healthcare workers that we are going to look upon to be stewards of antimicrobials. So I hope sitawabo sana. Apologies, I can't dance. Apparently it's the music. Nimesikia mkisema DJ weka inda. That's my route. Huku kwingine siko. So DJ, next time nikifunga unieke inda, nita dance kidogo. So, as it had been mentioned, that AMS is cross-cutting 4 departments, which are health, fishery, agriculture, and mining. So why these 4 areas? These 4 areas are the main points of use for antimicrobials in the day-to-day lives of humans. Another thing is it's usually confused between antimicrobials and antibiotics. Most of the time when someone wants to say antimicrobials, they'll say antibiotics, but it's all antimicrobials. So we are dealing with antibiotics, antifungals, antivirals, antimalarials, all those antis that we know. All of them are the antimicrobials that we are talking about today. And these antimicrobials, they are targeting disease-causing disease-causing microorganisms. So not all microorganisms that we want to target. As we know that there are good microorganisms that are beneficial to our body, so we don't want to get rid of them. We just want to focus on disease-causing organisms. That's why the focus now in management of disease, we've come from the broad empirical management of diseases to specific culture-guided disease treatment. When we say AMR, we mean antimicrobial resistance. And what is causing this resistance? as it has been mentioned by one of the speakers here, it is our habits that are causing this resistance. Our habit of abusing and misusing antimicrobials has led to the development of superbugs through resistance. So these superbugs are no longer able to be prevented using the antimicrobials. As I had one of the person, I don't know who is it. I can't see him, or maybe. The person who mentioned something about medicines being poisons. I don't know, who is that? Yes, yes. Yes, it is true. And I don't know whether the pharmacists in the house have been made aware of this fact that all medicines are actually poisons. That's why our regulator is known as the Pharmacy and Poisons Board. There's nothing like medicine. It's how we use the poisons that makes them medicines to us. So when we are handling medicines, I'd like to urge you to look at them as poisons. Poisons in that when they are abused or misused, they can lead to harm. That's a point to note. And this AMR has various implications to us. First of all, it's that we are losing lives. Is it true? Yes, there are deaths that are being caused by AMR. Like, for example, we are having a high number of patients who are on antiretrovirals that they have developed resistance to the first line, they've developed resistance to the second line, again developed resistance to the third line. So what is left to do is just to manage them during the end stage of life, because there's no more medicines that can be given to them that can save them, that can reduce the viral load for them to live. Again, the case that Dr. mentioned about antimalarials, coming from a region where we are having the malaria endemic in this region, high malaria rates. So this habit of going for antimalarials over the counter, it's leading to development of AMR. Okay. Being future healthcare workers, the responsibility is upon us to be good stewards of poisons. Let me use poisons. To be good stewards of poisons. What do I mean by good stewards of poisons? We are the people who are responsible for prescribing medicines, dispensing medicines, advising patients on how to use the medicines, managing medicine waste. That's where mining comes in, and management of pharmaceutical waste. We are the ones who are in charge of rational use of medicines. So when a patient comes, there's this thing known as the treatment guidelines. Has anyone come across the National Antimicrobial Treatment Guidelines, where it states the disease and then the antimicrobials that can be used for that disease? The first line is this, when that is not managing the situation. The second line is this. So we should act guided and not just be haphazard in the way we are dispensing and prescribing our medicines. Another thing that I noted that was not mentioned was waste management, which is very critical for us. For example, if I can ask my audience, where do we take our leftover medicines? Or they have expired in the house. How do you dispose them? Anyone? Yes, please. Mm-hmm. Okay, in the pit latrine. Another person? Where do you take your used up medicines?
So let me just talk of the majority. We include them in the trash bin that we usually use and dispose them as other waste.
And when you dispose them as other waste, where is it taken? To the west side, Sindo? And at the west side, they are exposed. They are not disposed in a way that is recommended. There's some guidelines on pharmaceutical management of waste where it depends on the level of medicines and how you are actually supposed to dispose them. Like, for example, the syrups, we are allowed to dispose at home. You just run them with your water and they go in the sewage. But antibiotics, it's not allowed to be disposed the way we usually dispose them. Because when we dispose them and in the open air, when it rains, the rain comes and carries the antimicrobials where? To the rivers. Sindo? What do they find in the rivers? Our food, isn't it? The fish and all that. Or even when it rains and it carries the rainwater to the farm. Si inaingia kwa shamba. Ikiingia kwa shamba, the food that is produced from there already is contaminated with antimicrobials, isn't it? We ingest that food. What were nutrition? Are we in? Nutrition? Anyone from nutrition? What is the trend lately? What are we advising? What is trendy in consumption of food? Are we leaning more towards organic or openly grown food? Kuna hiyo trend ya organically grown, organically this, organically that. That is what they mean. They want to make sure that the food you are consuming is not contaminated by antimicrobials. So that's why the nutrition department is here to guide us on what to do. So waste is supposed to, it is recommended, it is the practice, but it's not usually what we advise our patient. I see it mostly in CCC where it's advised that usipomaliza hiyo dawa, you bring it back to the clinic. But when it comes to the main pharmacy or the chemists outside here, once the drug is sold to the patient, you are done and dusted with it. So you should be playing that advisory role of advising your patients how to dispose their medicines correctly to prevent environmental contamination. Again, I had something about cancer and antimicrobials. How does cancer and antimicrobials relate? Do we use antimicrobials in treating cancer? Do we? Anyone?
I can't pass without saying something about AMR and cancer, because back then there's this type of Salmonella species that we use. So there's a form of Salmonella species that we use to attack cancer. Yeah. So this is how the bacteria works. It competes with the cancer on the available food. So at the end of the day, the cancer will be starved and it will die. So I think if I just don't know the exact relation, but there is a way in which AMR, the bacteria and the cancer are related. Thank you.
Okay, I don't know much, so don't tell me to explain. Yeah, all I know is that during chemotherapy, we use antibiotics. So.
Okay, so what I know is that chemotherapeutic drugs usually suppress immunity, and so a cancer patient on chemotherapy is more ako likely kushika microbial diseases, and so antibiotics may be used to treat him or her.
Actually, I wanted to say the same thing he said. You see, these cancer patients receive lots of these antibiotics, and these chemotherapeutics that include antibiotics, they make cancer patients more prone to antimicrobial infection because they'll develop its resistance. Thank you.
Oh.
Okay. Good afternoon. Okay, my name is Charles Odhiambo Tieno. I'm a public health student. Okay, now cancer cells are, as you know, are your own cells. They become malignant and they become pathogenic now. They start fighting your own system. As they become pathogenic, you must use antibiotics to kill it. Yeah.
Thank you for the contribution. I'd like you to take note that in Africa, we have the largest, the biggest burden of viral causing cancers, yani viruses that cause cancer. For example, HPV, hepatitis. Anyone, is that ringing a bell to anyone? Hepatitis ina cause nini? Liver cancer, sindio? HPV, cervical cancer, sindio? Now imagine we have antivirals that cannot kill these viruses. What does that mean for our burden of cancer? Is it going up or down? It's going up. Sindio? Again, these viruses that are causing these cancers, majority of them are preventable. How can we prevent them? Through vaccination, isn't it? What is the uptake of vaccines in Africa? Do we experience some vaccine resistance in Africa? Kama ya corona, wangapi walidungwa mpaka booster dose? Countable, sindio? So there's some vaccine hesitancy in Africa, sindio? That vaccine hesitancy is leading to our increased burden of cancer, sindio? In addition, there are antibacterial that are used to treat some cancers. And also in preventing diseases during chemotherapy and all that, we use some antimicrobials. So you can see how resistance and cancer is related, and how if we continue on this trend of resistance, our levels of cancers are going to shoot up. Sindio? I hope that is clear. Another thing that I wanted you to take note on was Daktari's question on before Fleming discovered penicillin. Although it's not documented, but we know that there was use of traditional and herbal medicine. like we said, the artemethyl lumefantrine, see, it is being produced from pharmacognosy means, that is herbal medicine. So what can this trigger in our mind? Is there room for alternative medicine apart from conventional medicine? Is there room for alternative medicine? I'll take the case for the recently former Prime Minister and how everyone was asking, with all that money, he went for pharmacognosy medicine in India and not the conventional medicine in Kenya. What does that tell you about the trend of patients trusting, the trust of the patient in conventional medicine? What does that tell you? Are our patients noting something that when I take this medicine, haifanyi kazi, sindio? So I'll have to look for alternatives. And what is that alternative? Traditional and herbal medicine, sindio? If they go through the traditional and herbal medicine and they're also using conventional medicine in conjunction to that, what does it usually lead to? Yes? Drug interaction. What else? Adverse events, adverse drug events, side effects. Huh? And are the patients usually, when they come to the doctor in the hospital, are they willing to divulge such information that natumia mitishamba? Wanasemanga? They'll use both medicines concurrently, sindio? So that is where also my docket comes in of pharmacovigilance. So you have to, when you're treating these medicines, when you're treating the patients, we have to check the outcome, the treatment outcome for the patient. Is the patient responding the way we were expecting them to respond? Are they deteriorating? Are they improving? If they're improving, are they improving with side effects, adverse events, and all that? Isn't it? Also, it can be that how many of you have interacted with poor quality medicines? Medicines that are maybe substandard. Have you ever heard of that line of thought? Substandard medicines, counterfeit medicines. We've heard of that. Those are the things that are driving up our resistance. When you bring poor quality medicines in the market, the trusting patient goes and uses these poor quality medicines. They're not improving, they are deteriorating. The medicine is of poor quality. So if you don't check the patient outcome and the root cause for the patient outcome, we are also missing out on a lot of information. There are ways that have been prescribed by the board on how to report poor quality medicines, how to report adverse events, how to report adverse events following immunizations so that our patients can be more trusting towards taking up vaccines. Sawa sawa? Yeah, that's all I noted when I was sitting and listening. I think more will be discussed in our panel discussion. But if I don't get another opportunity to speak, I'd like to thank you all for your presence, for your interactive time, and for being lively. So, thank you all.
Okay, thank you, Daktari. Thank you. We just want to start the panel session. The moderator and the panel members. The panel members can come. That is Sam Omolo, Sandra, Regan Origi, and Brian Uchibo. As they come, and Titus, Dr. Titus, yeah. it's going to be a 30-minute session. Then we'll just have our refreshments afterward. So let's just be patient and and get the wisdom. So as they come, a quick one. Ama namna gani? Si mnataka quick one? Si mnataka quick one? Now, what is the opposite? What is the opposite of antimicrobial resistance? What is the opposite of antimicrobial resistance? Who can try? Let me start with Mokoyo. Mokoyo, please. I don't want Ancrobial. I don't want ancrobial, yeah? Ancrobial, there's no ancrobial, yeah?
Antimicrobials collaborators.
Yes. Yes. Aya. Nani alikuwa na najibu hapa? Oh, yes. Then Steve, I'm getting back to you, yeah?
Hi. The answer is antimicrobial sensitivity.
Okay. So there's no opposite for antimicrobial. Okay, sir.
Antimicrobial susceptibility.
Okay. Nani bado ako nayo? Kwani hakuna collaborator? Ancrobial collaborator. Hakuna mtu amebaki hapa hivi. Okay. Thank you. Jibu, mnataka jibu? Hebu mnipatie mji. Mnakumbuka hiyo kitu ya kupatiwa mji? Nipatie mji. Sasa Garissa hiyo siwezi kubali. Nipatie ingine. Mombasa. Sawa. So nilienda Mombasa. After kuenda Mombasa nikawauliza pia hiyo swali. Wao pia wakasema aje? Hawajui. So let's think of it. We'll answer it together. Ikiisha. Sawa. Mimi pia sikuwa najua. Acha ni Google. Then tutaona. Haya. Let me where's the moderator? The moderator hadi kuna microphone. He will introduce the panel and they will do a 30 minutes presentation. Alafu tutauliza swali. Then we do the refreshments. Sawa. Yes. Some do the honors.
Good afternoon, everyone. So my name is Sam Omolo, a year 4 student studying pharmacy in Kisii University. And today I shall be your moderator on the topic as we are going to be discussing the impact, the drivers, and the prevention of AMR. So I'd like this to be an interactive session with you guys. Please be active and listening. And then if you have a question, you can note it down. If it's very urgent, you're allowed to raise your hand so that maybe our panel members wasisahau, okay? Okay. So let me use the societal norm. I'll start from my right. Which is my right? Yeah.
Okay, good afternoon. My name is Brian Ochieng, a fourth-year student doing biomedical sciences and technology.
Good afternoon. I'm Regan Origi. I'm a third-year student doing clinical medicine. Thank you.
Good afternoon, everyone. I'm Sandra Ongeji, a second year doing MBCHB, and I look forward to having an interactive session with everyone.
Another introduction. I'm Helen Okumu, pharmacist, KTRH.
Yes, good afternoon. Yes, my name is Titus Mutua Gashkira. Yes.
Okay, thank you. As you can see, the people in front of you are well versed in their topics. And let us start, ladies and gentlemen. So to my panel members, I'm sure all of you are aware on AMR, and I think we'd be, let us start by saying we'd be truthful with ourselves, right? This is something that we noticed over the last few years, especially with the advent of COVID-19 pandemic in 2020. So briefly, I'll start with the expert in the field. Theoretically, if there were another pandemic of an communically spread disease, for example, Streptococcus pneumonia, the methicillin-resistant type, okay? Do you think the infrastructure in the nation and globally will be able to combat it effectively?
Thank you. I would say, I'll start by saying I would hate to be in such a world. One, if you remember when we had COVID in 2019, it was not one of the first pandemics that we had of such. And per se, when you look at it in a global perspective, you remember clearly we had a very good origin of the pandemic in China, then it spread across the other parts of the world. But if we were to have a pandemic of the level that you just mentioned, you look at it in those now different parts of the world, we have cases of such infections everywhere in the world. So when, for example, we were trying to fight COVID, we were trying to curb probably entries from China and entries from probably Europe and the other parts of the world that were affected. But if we were to have an infection, for example, Pseudomonas, or probably an infection of, let's say, in a situation where our antibiotics are not working anymore against any of, let's say, bacterial infection or any other type of infection, it will be so difficult to handle it. We were discussing with Dr. Helen about the infrastructure of the Kisii County government, especially the healthcare, and it's wanting. I mean, like a simple, for example, simple things such as diarrheal diseases are a menace, and we are in a situation that we can't even handle them. So I would say that probably won't be equipped enough here in Kisii, and not in Kenya, and not in Africa, and I think not in this universe currently. Yes.
I'd like to echo the same sentiments. I don't, there will be some intervention, but it won't be full intervention that to the satisfaction of the one who's affected. We cannot say that, especially us in Africa, will have it easy, because even in COVID, we were more relying on donations than our own country seeking out interventions for us. So probably we'll go the same route after the West, and the ones responsible for discovering medicines have covered their own. That's when we'll be thought after as last. So probably the intervention that we should be more focused on is infection prevention. If we can really focus on that, even in our homes, hospitals, work, school, everywhere, infection prevention, that is the route that we should be more focused on.
Thank you. Okay. Dr. has mentioned the term intervention. Now, there are 5 levels in intervention of disease, okay? Infrastructure-wise. So the lowest level is level 0, where there is no intervention. Level 1 is there's limited intervention. Level 2, moderate. Level 3, majorly. And then level 4, full intervention. So where do you think Kenya and the rest of Africa ranks in the level of intervention?
Okay, so I'd say that Kenya, being part of sub-Saharan Africa, is a low to middle income country. So we're not really at the top when it comes to levels of interventions. I wouldn't say we are at the bottom as well. So I'd say we are at a middle ground in that aspect.
Yes, thank you. As you all know, Kenya is a developing country. Yeah, so we'll be at the middle. We are still developing 3. Yeah.
Level 3 is majorly. Level 2 is moderate.
Okay. Thank you. I think Kenya, we have the potential, but the facilities are missing. So I think at moderate, if we have the facilities, then Kenya, we are somewhere.
Thank you. Now, there are factors that have been leading to the spread of AMR. We've discussed them. They're social, economic, structural, and even biological, like the concept of selective pressure. Now, to the prescribers, all of us here are prescribers and dispensers of drugs because we live in a third world country. And the question to you is, what are the practices or what drives prescribers to dispense? For example, someone has come to you with a runny nose or someone has come to you with a cough. Of course, you're not supposed to prescribe an antibiotic. Of course, because, for example, a cough, you might use an antitussive or a suppressant, right? But what drives prescribers to do this? Because they still do.
So the factors may not be the same everywhere. For instance, when you look at in our setup, for example, here in Kisii and in Kenya, and I believe in other parts of Africa, patients have this belief that if I don't go home with some drugs, then I won't get better, right? So, and it becomes very difficult for any of healthcare practitioners to handle such patients. And I would say that that's one of actually the factors that is driving all these things that you see around. For example, but now over time I have learned that that can only be prevented by trying to build patient-doctor trust. I mean, the patient knows that this doctor is competent and whatever he says is probably what is true. But when you're in a situation where you have a patient with the flu, you have a patient with, for example, running some fevers, but you are not really clear on what should be done. That patient, you might advise them, okay, I don't think you need antibiotics. Okay. They say, okay, probably I don't need those antibiotics. But do you think that they will go home without those antibiotics? They will run to the next probably shop or chemist and they will get those antibiotics. So I think probably we can think towards that line of trying to create a very good patient-doctor trust, and that would probably help us in trying to advise our patient against using some of these antimicrobials. Yes.
I'll speak for pharmacy as a profession. So, what is driving antimicrobial resistance in terms of the pharmacy profession is the fact that we have become so profit-oriented. Profit-oriented in that I'll take advantage, I know what I'm supposed to do professionally, and ethically what I'm supposed to do. But if I tell this patient, you don't need this antimicrobial, just go home, you'll get better in 2-3 days. Here, I haven't sold anything at my pharmacy since morning. Nimekuwa tu na count magari hapa nje. So if someone comes, no matter how insignificant their condition is, I'd like to maximize on the profit for my business. So even if they don't need the antibiotic, I'll make sure they take the dose for antibiotic and the original one, ile expensive, to cover my business. Another factor that is driving resistance, I like to think of it as, what can I say, our practices or something still related on profits, that someone has a farm or has a chicken farm and they know that they should not, there's the recommended vaccination for livestock and all that, but I want to boost the growth. I want them to grow fast, to gain fat and all that. So what do I go for? I go for ARVs. I know that ARVs has that side effect of, it's called lipo something. It adds the lipids in the body. So what do I go for? I'll go for that. I don't even care what is the impact of someone feeding on this chicken after I've sold it to them, as long as I've made my profit.
Okay, thank you. The main concept of antimicrobial stewardship, we've come to understand it's preventing and containing the spread of AMR and also safe usage of antimicrobials. True? Okay, so there's a concept that was projected here today where it's been noted that most antibiotics are showcasing resistance to disease. Now, financially, how do you think this will impact the patient and the nation in general?
Okay. That's a tough question. Yeah, but I think financially, since in Kenya we are generally middle income earners, so if we can't afford the medication, then, and we can't prevent ourselves, then if we have the infections already and we can't afford the medication, then I think we will just be in a level where you just waiting for death while looking for other ways on how you can extend the lifespan. Yeah, but automatically, I think without financial support, it's death.
Okay, so if the common antimicrobials are resistant to the infection, then it's going to force the patient to spend more to get the higher antimicrobials that may not be commonly available. So it is going to impact the patient negatively in terms of finances because he's going to spend more to get the healthcare that you will have gotten with just the common antimicrobials. Thank you.
Okay, I'd say that financially it's going to affect not just Kenya but the whole world because it has been projected by 2050 there's going to be an economic loss of $300 billion to $1 trillion. So we can see that if we don't combat this early, it's going to suffer, it's going to cause a brutal blow to the world's economics. So at individual level, if the first line of antibiotics, okay, a patient has resistance to the first line, for them to acquire the second line of antibiotics, it's going to be expensive to them, especially the low-income earners, yeah? So it's quite sad that those that need it more have a lower capacity to afford it. So yeah, it's gonna be quite a bad side, yeah, because it's gonna have a huge economic and financial effect.
Okay, thank you. Now, I'd like to bring a